first, I will welcome everyone. Thank you so much for coming today. And then I am going to do our land acknowledgement. So IHSTS and the Type 2 Diabetes Network, which does its work throughout the province, would like to acknowledge that we are living and working with humility and respect on the traditional territories of the First Nations people of British Columbia. And now I will introduce the CEO of IHSTS, Kathleen Shunor, and she'll tell us a little bit about the Type 2 Diabetes Network.
Welcome, everybody. Thanks for joining us. I am the CEO of the Institute for Health System Transformation. It gives me great pleasure to welcome you to our September Vodcast put on by the Type 2 Diabetes Network. Just a couple quick notes. The Type 2 Diabetes Network it's a provincial entity, and really the focus has been working with partners to really design a different future for people suffering with Type 2 diabetes or those at risk of. The Institute for Health System Transformation and Sustainability has been around for a while. Type 2 diabetes is one of the major initiatives that we've been supporting with the help of our Ministry of Health colleagues. And now that I've got your attention, I also would like to ask if you haven't already signed up for the Type 2 Diabetes Network. This is one of several educational offerings that we have going on this fall. So I will, when I finish my little spiel here, put that website in the chat. If you haven't already joined, that would be fantastic if you could. So I will again thank you for coming today. And today's session is being recorded and is being moderated by my esteemed colleague, Krista Lamb. Krista Lamb is an author and a science communicator who works primarily in the diabetes and chronic health space. She's a producer and host of many podcasts, including the Beta Cells to Bicycles from the BC Diabetes Research Network and Unbreakable, the OC podcast from the Osteoporosis Canada. She's also an author of an award-winning book, Beyond Banting, about diabetes research in Canada since the time of Banting, and the creator of How to Talk About Health series. So I'll turn it over to you, Krista, for our exciting session today.
Wonderful. Thank you so much for that. And I'm so excited to see so many of you here today. One of the things I wanted to let everyone know up top is that this is a little bit of a different format. It is, as we've been calling it, a vodcast. So we're doing it podcast style. We're not going to make you sit through any PowerPoints. We're not going to show you a presentation. What we are going to do is we're going to have some conversations with two of my favorite people who are doing incredible research that I really think that you should know more about, both of which are working in the diabetes and mental health space. And so I'm very, very excited to have that conversation with them and to be able to talk to you about what I think they do that is really fantastic. So first and foremost, I'm going to introduce the first speaker, Dr. Mahavir Agarwal. And I am going to read the bio, but I think that once we have this conversation, you're going to see that he is doing a lot of fantastic things. So Dr. Agarwal is a scientist and psychiatrist in the Schizophrenia Division at the Center for Addiction and Mental Health, that's CAMH, and an associate professor at the University of Toronto in the Department of Psychiatry. He is also the medical head for clinical research in the Schizophrenia Division and co-leads the Metabolic Clinic and Clozapine Clinic at CAMH. His research looks at understanding the mechanisms underlying metabolic and cognitive dysfunction in mental illness, with specific focus on insulin signaling in the brain. And as I said, I'm a huge fan of his work, so I'm very excited to have this one-on-one conversation with him to start off our chat.
Thank you for having me, Krista.
Well, it is wonderful to have you here, and I'm going to the first thing I'm going to ask you is about how you ended up being someone who is a psychiatrist, you are a medical doctor, and then you decided to do basic research, foundational research, lab research. This is very rare for someone to decide to do kind of mid-career. So I would love to know more about that.
Thank you. That's an interesting question. I guess I was interested in research from the get-go. Even as an undergrad medical student, I was doing clinical research, actually focused on diabetes. But then I got into psychiatry because I thought of brain as the spinal frontier. During my training in psychiatry, I was attracted to the more biological elements of it, of cognition, imaging, and severe mental illness and so on. And I started getting interested in that and quickly realized that a lot of things in psychiatry are not modifiable, but what remains modifiable is metabolic health. And that has a huge impact on mental health outcomes, overall social and occupational outcomes, and even cognition. And so that got me interested in this field. And then so I did my training in India, my residency as well as my PhD, focusing on these related aspects. But then I came to the University of Toronto and CAMH for a fellowship. And I guess if you're working at CAMH and University of Toronto, you can't escape insulin for too long. Insulin has a rather storied past here. And so my mentors, Maggie Hahn and Gary Remington, have been involved in this work. And Maggie especially was focused on examining insulin in its various roles. And I got interested from the neuroimaging point of view. So that is the path that has led me towards this. It's very exciting because the medications that we use day in and day out, antipsychotics, interact significantly with the insulin system in the body and the brain, and provides you so many ways of both conceptualizing the problems that we face in psychiatry and also treating them. And so at the end of the day, I want to help improve outcomes by changing how we treat these disorders. And this interface allows me to do that. We also run the metabolic clinic. And so this research allows me to, do a quick sort of transition from research to clinics to back to research again, and to implement what we have learned in this research with our patients. So I feel very fortunate to be able to do that.
Well, it is very fortunate, and we're very fortunate to have you doing it. And one of the reasons is because there is this very distinct connection between type 2 diabetes and mental health. Now, we hear this all the time. Like, people are always like, if you have depression, you're more likely to develop type 2 diabetes. But I don't know that people understand why. It's one of those things we say, but I don't think we actually understand why we say it. Are you able to give us a little bit more of understanding about why there's such a deep connection?
Yeah. So you can approach this question from 2 points of view. So you could ask why diabetes is more prevalent in those with mental illness, or you could do the reverse and ask why mental illness is more prevalent in those with diabetes. These are overlapping questions. However, I've chosen to investigate the first question, which is why is diabetes and metabolic illnesses more prevalent in those with mental illness? So let me start there, and maybe Diana can speak about the second half, and we can have a conversation. So if you look at individuals with mental illness, they are predisposed to develop diabetes through a variety of factors. First and foremost is biological overlap. We have now understanding from genetic studies and proteomic studies that there is a significant overlap in the risk, the genetic factors that produce risk for severe mental illness such as schizophrenia as well as diabetes. So there is shared genetic risk and shared proteomic level risk between these two disorders. That these two disorders would overlap was known far back in the 17th and 18th century as well, where some of the early workers in the field would comment on the overlap, where they would say that families with mental illness also tend to have higher degrees of diabetes. So this is something that is inherently biological, which is borne out by several studies at various levels of sophistication. There's a recent from Denmark, there's a population level study that came out that described this just very well. So that's that. But then there's also this lifestyle piece. Our patients with severe mental illness, for a variety of reasons, don't have access to the best food, the best lifestyle. Smoking is a huge issue. Not having access to healthy ways of living life is an issue. And so that predisposes them to develop diabetes. There are also system factors. As much as we like it to happen, our systems are not really set up to communicate very well. So for example, the mental health professional may not be in a situation to communicate very well with the GP and vice versa. And that leads to in silo care, which overall leads to worse outcomes. And then some of our medications, while they're very good at treating mental health symptoms, they themselves add to the risk of metabolic health. So the most prominent among them are antipsychotics, the drugs I study the most and prescribe the most. They are very good at treating psychosis, However, they unequivocally increase the risk for diabetes as well by a factor of 3 times. And so these are some of the factors by which somebody with mental illness might have higher rates of diabetes.
Yeah, and you hit on something really interesting. I think it's something that when working with patients or people who live with mental health conditions is really important. I had a friend of mine say to me once that she felt, and I will use her words because I know that everyone is cautious around words, but she said, I feel like my choice is to be fat or to be crazy. And that really broke my heart because she was expressing that these medications that are supposed to make her better are increasing her weight. And so I know that you've studied a little bit around this and you have some thoughts on this. So I wanted to ask you about how your work looks at these things.
Yeah, I mean, she has expressed exactly the dilemma that our patients face. Like I said, so antipsychotics are the prime example. Uh, Antipsychotics are the cornerstone of management for schizophrenia and related severe mental illnesses. And study after study has shown that overall antipsychotics improve the quality of life and they prolong life for individuals with severe mental illness, right? So I would encourage you to imagine 3 worlds. The first world has severe mental illness, but antipsychotics have not been invented yet, right? And so in that world, our patients are likely only going to live about half their life, 40 to 50 years of life at max, because untreated psychotic illness kills people. Now, there's a second world in which antipsychotics do exist. And this is the world we live in, but there are metabolic side effects. So weight gain, diabetes, etc. And in this world, while our patients live 20 years longer, they still do not get to live the whole lifespan of an average adult, let's say 80 years. So our patients are dying at about 60. So we have gained 20 years, but we have not gained all 40. If it could ever exist in the third world, which is a world where we have all the antipsychotic action we require, but none of the metabolic side effects, we would potentially gain a further 20 years. And so the point your friend made is very relevant because weight gain is one of the major reasons, the biggest reason why patients go off their antipsychotic medications. And then some of our research has shown that this is in fact treatable, preventable, and this is something that they don't have to deal with if we are proactive with our management approaches. And we have also shown that if you do take these proactive approaches, compliance with medications improves.
And your work is looking a little bit at the physiology. So you look at insulin in the brain and how that can have an impact. And so I'm going to ask you to tell us a little bit about what that is. And I think before we start, we have to lay the groundwork because I didn't even know we had insulin in the brain. And so I figure we should talk about that first.
Oh, I didn't know either until a few years ago. Insulin was a peripheral hormone for me, a body hormone for me. So there are some elements of this which are an active area of active research. So for example, does the brain produce its own insulin? We don't know yet. It is possible that some of the neurons produce insulin. However, what we do know is that insulin eventually finds its way into the brain. And it appears that most of it happens through the circulating insulin in the rest of the body. Now, insulin in the body, we know is relevant to controlling glucose levels. It has a role to play in managing fat levels and all the other peripheral metabolic aspects that insulin takes care of. Now, insulin in the brain has a role outside and linked to this as well. So when we look at overall glucose regulation in the body, there's, from what we understand of the research, the brain plays a significant role. So there are brain-based processes which are linked but somewhat independent from the pancreatic processes in how they manage glucose. So hypothalamic insulin signaling can shut down hepatic glucose production, and that is a way in which it can regulate glucose production in the body, especially in the postprandial state. We also know now that insulin in the brain may have a role in cognition. It may also have a role in deciding eating preferences. And then there's some data that would suggest that it could potentially have a role in determining symptom severity in illnesses such as depression and schizophrenia. This is very much still an area of progress. We do not know as much. as we would like to know, which is why I'm very interested in this. Everything you find appears to be new and exciting and interesting. But yeah, insulin in the brain is a major player, and now it is hypothesized as this as a crossroads of sorts between metabolic and cognitive disorders. So if you think of diabetes or Alzheimer's disease and other mental illnesses, it appears that the cognitive dysfunction that some of these disorders share is likely driven by abnormalities of insulin action in the brain.
And so learning all of the things that you've been learning about this in your research, has it impacted how you're treating patients? Are you looking at things that might help people who are dealing with this elevated type 2 diabetes risk, this elevated risk of excess weight, and their medication?
Yeah. So this is sort of the crux of why I love the clinician scientist role so much. So we have now separate lines of evidence to show that even the first dose of antipsychotic can induce changes in the way insulin functions at the level of the body and at the level of the brain. We have human and rodent data showing that antipsychotics very quickly produce profound disturbances in glucose metabolism in the body even before weight gain sets in. And then we have data from the other end which show that you can use drugs like metformin to primarily prevent the onset of metabolic dysfunction. And then we have more data both from our center and centers across the world that show a steady pattern of decreasing returns as you delay this intervention. And so you seem to get the maximum bang for buck if you start sooner. And so we have worked towards new guidelines. So the Canadian Obesity Guidelines is an example where some of our data has led to a policy change. And so now Canadian Obesity Guidelines recommend starting metformin for both prevention as well as treatment of antipsychotic-induced metabolic dysfunction. Because of our data, CAMH policies have been revised to offer metformin whenever a high liability antipsychotic such as clozapine is started. And so what the sum total of research is doing is to show, one, how big a problem it is, and two, also to show how manageable this problem is if you start early enough. And so it has been our focus to train and retrain psychiatrists, especially residents, and to inform them of this evidence so they become comfortable in managing metabolic dysfunction very early on, rather than leaving them for the GPs or internists to solve when the problem becomes quite large. No pun intended.
Yeah, and I love that this is now a guideline. I think that for those that are watching or listening, the Obesity Canada guidelines are really a wonderful tool. And so I highly encourage everyone to take a look at those if you haven't already. And that is going to lead me into my next question for you, which is, we are now talking about metformin, but there's so many new diabetes drugs on the market. Has there been any research yet into those drugs, or are we still at the metformin stage with research?
Oh no, there's accumulating research. So I mean, a lot of the excitement, and rightfully so, is around semaglutide. But semaglutide is not the first GLP-1 receptor agonist drug. So that's the family of drugs that belongs to. So there's already research with its previous cousins, liraglutide and exenatide, within the mental health space, and they seem to be effective. They reduce weight by about 5 kilograms, which is something, but nothing as significant or as sort of eye-popping as semaglutide has been able to sort of generate in terms of buzz. And then there is a newer drug called tirzepatide, which seems to be even better in terms of weight loss efficacy than semaglutide. Our center published the first case series evidence of use of semaglutide in a severe mental illness, and we were able to show that in a group of 12 patients who were not responding to metformin or not losing weight with metformin, they went on to lose an average of 8.5% body weight in 9 to 12 months with semaglutide without any significant side effects, including mental health side effects. So that was the first demonstration of its efficacy in our population. There are at least 5 clinical trials that are going on examining semaglutide in severe mental illness, including in our center and in centers across the world. In the next 2 to 3 years, we should have some evidence about its efficacy. There are, of course, some concerns around, constipation and potential worsening of suicidality. tentatively, we are not seeing that much of it yet, but of course, it needs to be investigated in full detail.
Absolutely. So super interesting and exciting. There's so much exciting stuff. And I was going to ask you as my next question, what you're most excited about now to sort of wrap up our interview with my last question, but there's so much. It's really exciting. So what would you say is, what are you excited about right now?
Yeah, no, it is. I'm excited at the two ends of my portfolio. So at one end, I do this neurobiological research with insulin in the brain. So at one end, I'm trying to figure out and demonstrate in humans. So we have some data in rodents, but we are now trying to show in humans what exactly insulin does in the brain and how some of the drugs we prescribe interacts with it. How, for example, we have a study going on in youth with depression in early stages, and we are examining insulin in the brain in them to figure out if depression and insulin resistance in the brain go together hand in hand, even before medications become a factor. And on the other end, we have these clinical trials going on, and we want to demonstrate the effect of this drug in this population, because unless you have clinical trials, guidelines don't move. And so it's these two extremes of my work that I'm the most excited about in the next few years.
Amazing. I am so glad that we had the opportunity to talk to you about this. And I'm going to ask anyone who has questions to pop them into the chat. We really want to have a wonderful discussion at the end. Both Diana and Mahavir will be back to talk to you in the panel at the end. But for now, I'm going to invite Dr. Diana Sherifali to join us on the screen.
It appears that my video is controlled by someone else.
Oh, well, that's a problem. Let me just see if I can fix it. There we go. Technology is my favorite until it isn't.
It says that the host has stopped it.
There we go. Oh, that's Carly. I'm turning on cameras.
Okay, wonderful.
Beautiful.
Here we go.
Here we
Okay,
go.
great.
That's probably my fault. Technology is my friend until it isn't. So thank you to everybody who is joining us for this portion of the conversation, which will be with one of my favorite people, Diana Sherifali. So let me tell you a little bit about Dr. Sherifali. Dr. Diana Sherifali is an associate professor in the School of Nursing at McMaster University. She is also the inaugural holder of the Heather M. Arthur Population Health Research Institute Hamilton Health Sciences Chair in Interprofessional Health Research. Her research program aims to optimize the management of diabetes and quality of life for older adults and people with diabetes across their lifespan. And I have had the pleasure of working with you a number of times and always enjoyed it. And I'm looking really forward to this conversation. But first, I'm going to ask you about the role of a research nurse, because research nurses are something that I had never really thought much about and have realized are fairly rare still, but becoming more of a profession. So I would love to hear how you began your journey in research.
Well, thanks for the opportunity to talk to all of you today. So I sort of stumbled onto diabetes research as a research nurse. I started to do some graduate work just based out of curiosity and really a conundrum that I was facing with some clinical scenarios as a nurse diabetes educator. And with the good fortune of having really lovely and supportive peers and interprofessionals that I worked with, physicians, endocrinologists, other nurses, other dietitians, I was able to sort of promote my questions and be curious and continue to be curious and pursued graduate work. And to that end, just had really a great opportunity to be mentored. Similarly to Mahavir, in going to Toronto, you can't avoid the discussion of insulin at University of Toronto. At McMaster, you can't avoid the question of evidence and what is evidence and, how do we get it? So at McMaster, we're always approaching things as a problem and how do we find solutions for problems? We may not find all of the solutions, but we bring in teams and interprofessionals. So I think this really resonates with kind of diabetes as a as a case scenario for team-based work and collaborative work. It certainly speaks to and lends itself to the questions that I might ask as a nurse, but also as a caregiver for a family member that lives with type 2 diabetes, certainly someone that's trying to prevent diabetes in my own world, but also just, as part of an interprofessional team, whether it's mental health, diabetes, pediatrics, et cetera. So.
Yeah, and it's really exciting because you've worked in a number of areas of type 2 diabetes that are really interesting, frailty and all sorts of areas preventing hypoglycemia. But recently you really focused a lot on health coaching. And I would love to know, what do you mean by health coaching? And what is the role of health coaching in helping to support people with type 2 diabetes or at risk of type 2 diabetes?
Right. Thanks for this question. The way I came about health coaching is really, it sounds cliche, but it was a moment, an epiphany moment with a patient partner that was part of a research study. And this study was published as part of my postdoctoral training following my PhD under the supervision of Dr. Herzl Gerstein, where we found no difference in our study. And that is catastrophic, especially for a postdoc fellow, a trainee, you're trying to make it in your own right. And it was something to the effect of, we were providing education to people and wondering whether this education, paper-based education, would actually change behaviors. We figured if, we provide people with knowledge, they're going to go and change behaviors. And the gentleman, I'm paraphrasing, he basically told me that the paper that he received didn't talk to him. And I thought, wow, I completely missed the boat. So that was about, 17 years ago. So I would say probably in the last 12 to 14 years in particular, I've really been honing in on this concept of health coaching. And for me, and I've written about this, health coaching is really the conduit between guideline-based care, sort of, what are ideals, which I think are important to have, goals of care. And then they're the conduit between goals of care and what does life look like, the reality for people living with or at risk for diabetes, type 2 diabetes. So for me, it's a care translator. So it's, how do we break down these massive concepts? And I say massive concepts around self-management, around education, around knowledge, skills, behavior, and how do we break that down into opportunities for people to ultimately achieve goals that reflect their best personal self, not what others are putting on them, but their best personal self. And in full disclosure, I think what really was sort of synergistic in even my own experience as, a varsity soccer player, the idea of coaching really spoke to me. And I've had, again, professionally and in nursing, some really great mentors, but also through sports growing up. So that's a nod to anyone who can obtain sports or access sports, and the importance of that as well.
And I know that there was recently a pilot of this project that you've been working on with health coaching. Can you tell us a little bit about that and how the healthcare providers found it? Because I find so often the healthcare providers are like, oh, another pilot. So how did they find it?
Yeah, so the health coaching evidence, I would say in particular, we've built a really good foundation around evidence to support it. So this has been published, whether it's, cost effectiveness, lowering some of those clinical markers of care, glycated hemoglobin A1C, but we've been able to demonstrate improved quality of life, et cetera. Now, the beauty of diabetes management is that it's a big tent conundrum. So we're always looking for opportunities to think and reflect on what are some of those challenges that we anticipate, but also what are we seeing clinically, similarly to what Mahavir is talking about. So I had the good fortune of a couple things. One is being part of Diabetes Action Canada, a wonderful network that brings people that are like-minded together from totally different areas. Never would I imagine that I'd be connecting with folks through CAMH, Center for Addictions and Mental Health. And So was able to connect with a great colleague, Dr. Peter Selby, and then through that journey was able to work with mentees, trainees, and I'll give a shout out to Dr. Carly Whitmore, who's also on this webinar right now, or Vodcast. So again, some of us had more diabetes expertise, some had more mental health and training that way, whether it was nursing or psychiatry or family medicine. And we collectively came from this perspective, including that sort of patient voice and lived experience around what are we trying to do here? And so we knew that it was anchored on a couple things. Health coaching in self-management support. We also knew that we needed to push mental health well-being to the forefront. This wasn't just about lowering A1C and glucose levels. This was something else. This was flipping the paradigm a little bit. We also knew that, with COVID, we learned pretty quickly that we could implement technology. It's not always perfect, but, let's not, throw out everything in spite of perfection and the latest and greatest app. So the pilot study was actually looking at using something that CAMH had actually developed. So using their innovation and using a health coaching innovation from a diabetes world and bringing it together. And so I think this was just such a synergistic sort of like explosion of enthusiasm, learning opportunity, and excitement around this pilot study. So it was led by Dr. Carly Whitmore, Dr. Peter Selby, and myself, and really looked at using omnipresent technology. So imagine something like WebEx Teams, something like Zoom for healthcare professionals, or Microsoft Teams, where it's readily accessible in our healthcare system, but can we leverage that technology to address mental health and well-being for people living with type 2 diabetes? So the inclusion criteria was essentially anyone who was interested, who identified as someone needing support for mental health issues could enlist in the study, generally speaking. And what they had access to was a virtual health coach for 8 weeks. And that virtual health coach was also sort of interacting with the individual, but then once a week would round, or what we would call rounds, like medical rounds or healthcare rounds, with an interprofessional team. So that team comprised diabetes folks, mental health folks, nursing, physicians, recreational therapists, you name it, who would sit and listen together, as well as patient partners. And so collectively, they were learning and reshaping items, going back to the health coach and the health coach to the participant. So in a general sense, I think it was very successful. We're looking for more opportunities to scale this up. From a healthcare perspective, I think it sort of broke a ceiling that we typically talk about when we talk about integrated care. And just bear with me for 1 minute. Integrated care often is referred to when we talk about diabetes and mental health. We're integrating conditions or diseases. What this pilot project did was integrated people and integrated professionals to learn from each other, with each other, for the betterment of patient care. So I think that's something that I'm really excited about.
Yeah, absolutely. And it's something that I think is really important about this. And one of the things that I think is really interesting that people who are listening or watching right now might not know about is diabetes distress, which is the idea, of course, that there's a very specific mental health condition that can come with living with diabetes. And I wonder if that's something that you factored into the health coaching.
Absolutely, yes. And actually, health coaching in general, what we find is health coaching is really a self-management support strategy. And I would actually argue it's not self-management, it's self-care. And so the health coach is there to support in terms of that non-judgmental monitoring, advice giving, problem solving, a little bit of that just-in-time learning and education. So it's really problem-based, very centered around adult education. There's also a component of psychosocial well-being. So checking in with, hey, what is the conversation that you're having with yourself about your diabetes, right? So giving individuals sort of that opportunity, that flexibility to just check in. So not everyone will have access to a paid scale or a diabetes distress scale, but diabetes distress, and I want to get this correct here, really looks at a couple domains. So one is the emotional burden of living with diabetes. Okay, and in this case, it was type 2 diabetes. It also considers the regimen distress. So as Mahavir talked about, there's some wonderful new medications that are once a day, once a week that are game changing. But what about folks who have to dose their medications multiple times a day? Insulin, even some older adults are on multiple pills that are not conducive to, managing their diabetes. We also consider interpersonal distress as an issue. We know that many folks have friends, families, siblings, colleagues, personal, professional partners, etc., that may be, checking in on them, but it may seem as a little bit too much and almost policing. So sometimes those dynamics can go off kilter. And then the final component is what we would consider physician related distress. And again, this is not pointed to physicians, but I think we could probably generalize this to healthcare distress. So there's just not a good connection, trusting therapeutic relationship. And in all fairness, sometimes the system, the healthcare system, isn't built in such a way that we can take the time and actually foster that trusting relationship, which health coaching can.
Yeah, and I love hearing about this because I think that there is some sort of I think a barrier. Like there's this sort of like when you go to see your physician, that person isn't always listening to the entire story of your life, understanding the barriers that you face, understanding all of the things that might be impacting your health goals. And there's also a lot of weight bias in medicine. As someone who has struggled with my own weight, I know that these are things that people who go into the doctor's office may feel very uncomfortable about. So how are things like weight management and the shame and blame that can come with type 2 diabetes better managed with health coaching?
Yeah, so health coaching really works with individuals to set and reframe what does health and wellness look like for them. So one of the things we don't do is goal set. And so I think it is as simple as that may sound, there are many instances in some literature where goal setting or the idea of sort of self-managing is actually not a benign intervention. There can be further perpetual sort of spiraling and blaming and shaming. Oh, I didn't hit my goal. I now have to go back to my diabetes team and say I didn't do this in the past 3 months. So what health coaching offers is frequent and sort of low dose strategies to address complex behaviors. So we're really translating this down into tiny habits. And the tiny habits are really anchored around what is simplified, realistic. These tiny habits can be done for 30 seconds, even a minute. So it could be something like doing some wall push-ups, countertop push-ups, squats, listening to a song, putting on a song just to sort of de-stress a little bit, but dancing to the song and finding joy and satisfaction. So not so much, you have to achieve this goal in 3 months, but these small, tiny habits that are planted, seeded, nurtured, and celebrated so that they grow in and sort of succession and stack on each other to ultimately get people to these broader health-related goals that healthcare providers often talk about.
So interesting to me. And I'm very excited to get to our panel talk, but I want to ask you if there's anything about this program that you would want healthcare providers to know that I haven't asked you yet, or that I haven't talked to you about, or even people living with diabetes or at risk of diabetes. Are there things that you think are important for them to take away from this program?
Well, I think as it relates to diabetes, mental health, and health coaching, I think we are on the cusp, as Mahavir talked about, from sort of different ways of thinking about this. For me, what excites me is that there's growing recognition that this isn't something that will just go away, but something that we openly have to discuss and work together to find solutions. The other thing that excites me is that there are simple and elegant innovations, and those innovations are talking and sharing feelings, experiences, emotions, etc. So for me, it goes back to, the gentleman in the clinical scenario that said he wasn't surprised that my study didn't work because paper didn't talk to him. So despite all of the fancy Apple Watches, gadgets, you name it, whatever we have to help change behavior, sometimes the most elegant solution is talking to people. And can you imagine, if we were able to amplify, scale up that support through technology as a tool, but not replacing that human connection, I think we would all be better off.
I absolutely agree. And I loved talking to you about this. And I'm so glad that you're going to stay with us so that we can have this panel discussion, because we did get some questions in advance. And I also have some questions for you, but I'll get Mahavir. Can you come back, or do you have to? Oh, there we go. Beautiful. We fixed that. So we will have a panel discussion. So if you have questions, please drop them into the chat and I will endeavor to get to all of them. But I'm going to start with the first question I have is really about why is it important that we're having this conversation about mental health and diabetes now? Diana, you just touched on this a little bit, but I think it's also really important that we talk about the fact that things have changed a lot over the last few years, even the years I've worked in diabetes research. We're in a different place. And so why is it a good time to be having that conversation? And I'll ask you, Diana, first, and then Mahavir, you can answer.
Well, I'll start by saying there's a lot of interesting research that's being done, and Mahavir talked about this from sort of the biological or basic science perspective. Even hearing about insulin in the brain, that may be new to many of us. I'm also intrigued by the questions that are being asked, not only by nurses, dietitians, clinical psychologists, but collectively as a team, especially when we're reflecting on this and working with patient partners. So we're all learning from each other. We're creating new and different solutions that are tested in research. And ultimately, this is about advocacy, changing how we speak to one another, how we care for one another, and ultimately how we are approaching this as a condition that many people are living with or at risk for.
And Mahavir?
Yeah, no, I couldn't agree more. Diana nailed it. I mean, irrespective of whether you look at the micro level or the macro level, it's about breaking down traditional silos. I mean, you have to appreciate how science or medical fields or treatment sort of evolves over time. And mental health and diabetes have historically been not closely linked in terms of, physical location. They have been located in different institutes and different hospitals to people who think about these as related. Diabetes is a out and out peripheral body disorder, whereas mental health is completely in the brain. It's only recently that we have realized that, there's significant crosstalk, that dualism that has historical roots is still prevalent in many ways of how our hospitals and our research programs are structured. And so whenever you're trying to bridge these gaps, it becomes a challenge. It's a new challenge. It's exciting, but it's challenging this all the same, because the fields as of now are not prepared to fund that kind of research or maybe take that risk of bringing the two fields together. So BBDC, for example, the Banting and West Diabetes Center, is one of the leading places where you're allowed to do some of this research. I mean, BBDC happens to be one of my prominent funders because they like this overlap between mental health and diabetes. A lot of times this is not appreciated. So that's, and now that we are talking about it, more and more people are coming around to it because there are a lot of gains to be had, to Diana's point. Again, right from understanding the molecular basis to whole person management and team management, there's so much we can learn from each other. We're ultimately talking about chronic illnesses. And at the heart of it, it's about sort of sticking to a game plan and making sure we are able to do as much as we are able to do in a given patient and at a system level.
Wonderful. And so we've had a bunch of questions come in, so I'm going to turn to those. So the first question that came in was from Dr. Erin Mulvihill, and it is a question that I think will be, I don't know, it could go to both of you, but I think it might be more a Mahavir question. And she wants to know about the role of leptin and leptin resistance in addition to insulin signaling in the brain.
Yeah. So these molecules, so we like to, sorry, let me think it through. In research, we sometimes have to, by necessity, focus on one molecule or one pathway. it doesn't mean that it's the only thing that determines the outcomes of interest. And so leptin is another one that has many overlapping functions with insulin, especially in the brain. And so while I was talking about insulin work, our lab led by Maggie Han is doing leptin work as well. And so like antipsychotics have been found to induce insulin resistance, they also induce leptin resistance. However, the way insulin and leptin work seem to be slightly different, which might allow us to tease or work between these two systems to discover novel therapies. We are still at very early stages, so it's very difficult to say for sure. But yes, these are our bodies are immensely complex with overlapping but distinct functions assigned to several molecules, and insulin and leptin happen to be two of those within the brain. And the body, of course. And so, yes, leptin is very relevant. I haven't gotten around to studying it in humans yet, though, and I hope to do it in the next few years.
So something to look forward to. And Diana, this one I think is a little bit more framed towards yourself, although I think both of you could answer this one. And it's from Claire Zalay-Timbo, which is a general question. How can people working wider within public health make this important connection across subspecialties and highlight the connections in our day-to-day work?
Great question. I think it starts with a greater recognition of the role of stress and mental health, just even in day-to-day, whether it's, healthy eating, being active and finding joy in activity, finding time for self-care, how you sleep, your sleep hygiene. I know our colleague at CAMH often talks about the 6-pack of behaviors, right? So a little sort of tongue-in-cheek, but nutrition, physical activity, smoking cessation, alcohol intake, your sleep hygiene, and then how are you managing stress? So just having that check-in with yourself in the busy, busy world that we're in right now, despite all of the conveniences, why is it that stress is going up? I'm sure we've all heard about the polls about research that parental stress is on the rise. So why is that? And I think it just goes back to, we need to find opportunities for small, healthy habits. I think we're just kind of caught in this perpetual self-deprecating cycle of, I got to set this goal. My watch is telling me I didn't meet my goal yet. I personally took off my watch and I tried to do more organic, fun things that I'm curious and interested about, including playing Lego. I've rediscovered Lego. So I get off screens and it brings me joy. But all kidding aside, I think from a public health perspective, it is just a greater awareness, first of all. Second of all, looking for any opportunity to implement self-care. So whatever it might be, decreasing screen time, acknowledging sleep hygiene and how do you improve sleep hygiene, nutrition, physical activity, whatever it might be. And then if we can all collectively move people into that right direction or optimal direction for themselves, that's a good place to start.
Yes, I think that's really excellent. And Diana, it's good to know when I need someone to build me a Lego car. Last time I had to get a 13-year-old to do it for me. So we have a question also from Sean McKelvey from the Institute for Personalized Nutrition. And the question is for Dr. Agarwal. Yesterday, Dr. Chris Palmer, a Harvard psychiatrist, testified in front of the Congressional Committee on the promising role of ketogenic therapies in treating mental illness. Dr. Anna Andreza of U of T is researching this area as well. Can you please comment on their work and where lifestyle interventions fit into your research on metabolic health? So I will turn that over to you. I don't know if you are familiar with those researchers, but hopefully you are, and I will ask you that question.
Thank you, Krista. This is a great question. And yes, I'm familiar with these individuals. So Dr. Palmer has written a book detailing some of the ways in which ketogenic diet can help with mental illness. To provide some background, ketogenic diets are diets that are supposed to induce a state of ketosis in the body, which is when our body, instead of using carbohydrates as the primary fuel, switches to using ketones. And so the body is primarily powered by ketones. And the way to do that would be to restrict significantly carbohydrate intake and up the protein and fat intake. There are various ways of doing it, most commonly with dietary interventions, although there are some supplements that are beginning to be available. So that's Chris Palmer's work. Anna Andreasa has taken a very intensive biological lens to this in a related manner, in that she's studying mitochondrial abnormalities across a variety of disorders, including mental health. And so her hypothesis is that mental illnesses are ultimately metabolic illnesses. And if we were able to bypass the metabolic problems that exist in mental illnesses, if our neurons were able to use all the energy that they could possibly use in the right way, then perhaps mental illnesses could be improved. And so these two are connected, in that ketogenic diet could be a way in which we could bypass some of the broken elements of energy use in neurons and make better use of ketogenic sources. There's a lot of excitement around this work, and it does seem interesting. Although up until now, so I have not been able to implement this in my clinic because the evidence is not there yet in terms of clinical trials. These are very interesting hypotheses, and I hope adequately powered studies and rigorously conducted studies are able to test these ideas out. As of now, the evidence that exists within the context of mental and metabolic health, so again, I'm talking about antipsychotic-induced metabolic dysfunction. Within that space, diet and exercise-based interventions have so far not been very impressive. I'm not saying they don't have a role. They are the building blocks on which you base an intervention on. So you advise diet changes and you advise exercise, and then you add a drug like metformin or semaglutide, depending on what's indicated. But up until now, and these are studies which have not tried ketogenic diet, to be clear and fair. These are studies which have used other ways of dieting, like calorie restriction or sugar restriction. They have tried to do exercise routines or CBTs, etc. They have so far only provided mixed evidence. One of the largest studies showed that it was neither cost nor clinically effective. So that's where the evidence is. But that does not mean that there cannot be lifestyle intervention in the future that might positively impact not only metabolic health, but also mental health. Ketogenic diet looks like a promising candidate, and I would be really interested in finding out if it helps. It would be wonderful. I mean, we are so far behind. So since we are talking about mental health and diabetes, I think it should be pointed out that in the last 60 to 70 years in psychiatry, we have not discovered a single new mechanism of action. We are still stuck with the synapse. We are still stuck with the dopamine receptor for psychosis and the serotonergic receptor for depression. We really haven't had a significant move forward, although things might change in the near future. On the other hand, in diabetes, we seem to get a whole new mechanism every 10 years or so, which is just amazing, and which is why people like us keep looking to diabetes for the new drug and then try to implement that in the mental health space. So there's a huge disparity, and anything that can help with that is very welcome.
I know, Diana, you had something to add, so I'll
I just want to add, and thank you, Mahavir, for sort of teeing this up. And I love how you eloquently said diet, nutrition, and activity or exercise interventions are sort of the foundational pieces. I think I always appreciate sort of the clarity in the language, and especially in this space, diabetes and mental health, when we talk about lifestyle, et cetera. There's an assumption that there's a choice. And I think we never want to go into that discussion thinking that people always have a choice in terms of nutrition patterns, eating patterns, how they access food, et cetera, or physical activity for that matter. So one of the things that we're always struck with is that, you know, type 2 diabetes in particular is not always a democratic disease. We know that. And oftentimes it impacts folks who are underserviced and underrepresented. And we know that that is also perhaps where we're seeing more of the mental health challenges around addictions, et cetera. So it would behoove all of us to think a little bit about, you know, as we're talking about diabetes, mental health, and some of those nutrition, diet, physical activity, or lifestyle interventions, you know, how are we ensuring that folks are able to access this from sort of a social, sort of ecological, environmental level? We know that more and more communities are food deserts, food swamps, where access to green space, places where people can be active in nature, buy healthy, fresh fruits and vegetables, is few and far between. So I just wanted to kind of highlight that one point too.
And it's a really important point. And so I'm going to take the last question, which is from Dr. Carly Whitmore, and we've talked about some of her work today. And so it's kind of an extension, and it's an area that I'm really passionate about. So those of you that have seen me speak before know this. And it's not lost on me that when we are talking about mental illness, diabetes, and living with obesity, we are talking about compounding experiences of stigma, and these experiences of stigma challenge access to care and health outcomes. Based on your research and clinical experience to date, how can we begin to dismantle these layers of stigma within health systems to ensure that those who live with these intersecting conditions and health challenges receive compassionate, equitable care? So an incredible question. We only have about 3 minutes, so Diana, I'll give it to you first, and then we'll try to quickly answer that.
Yeah, again, I've had the great fortune of learning from Carly, and she's obviously posed a very challenging question, but also folks, we've learned from our Indigenous communities and people who have shared their experiences. So really approaching all of this as, adverse events that have occurred in life, right? A trauma-informed lens. So are we now stacking further trauma, stigma, and shame, and how do we disentangle that? I don't know, but I think the first opportunity is to really reflect and say, this is someone that lives with multiple long-term conditions, not by choice, not by design, but by a myriad of complex situations. And so I think that's the value of bringing people together, such as, Mahavir, myself, the diabetes, the mental health world, patient partners who have such rich lived experience that help us understand that this is not just a label of you're living with diabetes, but there's so much more complexity to this. And I think if we can share some of that compassion right out of the gates, that would be helpful.
All right, and Mahavir, I will give you the last one.
Yeah, I agree. There are many right answers. I mean, there are many answers to this question. And like Diana said, there's no simple answer. I mean, in my role as a biological sort of researcher and psychiatrist, I agree with Diana. And I would also like to add that better solutions take stigma away. Better treatments take stigma away. So I would like to take the example of tuberculosis and HIV. They were massively stigmatizing illnesses, and cancer up until a few years ago. What changed, aside also from the advocacy, of course, that helped, but what also helped was amazing treatments that no longer make this an issue. So imagine tomorrow if you could solve schizophrenia or bipolar disorder, or a drug for diabetes solved all these overlapping problems of obesity and hypertension and cardiovascular illness. Suddenly you have a drug that you take once a week or less, and then you're healthy, or at least not bothered. And that would go immensely in reducing stigma. Again, these are pipe dreams, but this is how you can conceptualize treatments, and hopefully one or some of them come true in the near future.
I love pipe dreams, because I think that's how we find things like insulin that we've talked about a few times. That's how we change the world. So I want to thank both of you for joining us today for this conversation. It was our first time at the Type 2 Diabetes Network doing the Vodcast format. We would love to find out what you think. So please do let us know if you enjoyed this and would like to have more of them. I will also encourage everybody who is here today or listening to join the Type 2 Diabetes Network. It is free to join. There are tons of resources on the website at t2dnetwork.com, and we would love to have you join us and ask and use the resources. And for the next webinar, which we are hoping will be announced soon, we will be looking forward to even more great conversations. So thank you to everyone for joining us.